Stay safe online. UITM Research Live Webinar Series 2.0 today. I'm AP Dr. Noor Mohd Kasim, an Associate Fellow of IP Perform and Department of Pathology, Faculty of Medicine, UITM. I will be the moderator for this session, okay, inshallah. So before we begin, okay, please allow me to introduce our speaker for today. Okay, so we have today, we are so glad that we have Associate Professor Dr. Noor Shafina Noor. Okay, she's an Associate Fellow of IP Perform, a Center of Excellence in UITM. She completed her medical degree from University College Cork, Ireland in 2005. She then obtained her pediatric membership from the Royal College of Physicians, Ireland, and became a general pediatrician. She continued her subspecialty training in University Malaya Medical Center and Children's Hospital of Pittsburgh, Pennsylvania, USA, and is currently serving as a consultant pediatric endocrinologist in UITM. Currently, she is the head of Department of Pediatrics, Faculty of Medicine, UITM. Her research interests are all fields of pediatrics endocrinology, especially in diabetes mellitus, obesity, thyroid disorders, familial hypercholesterolemia, and endocrine disruptor chemicals, for example, bisphenol A, BPA. So I think there's a short summary for CV for AP Dr. Noor Shafina. So without further ado, I would like to invite Associate Prof. Dr. Noor Shafina Noor to deliver her talk on diabetes mellitus and obesity in children. So Dr. Shafina, are you ready?
Okay, let me start. Thank you so much, Prof. Alice, for the kind introduction. And I'm so honored to be here today to share some knowledge and some experience. So the title that I've chosen today is Diabetes Mellitus and Obesity in Children. I'm with the Department of Pediatrics, Faculty of Medicine, UITM, and also Associate Fellow of iPerform. So I have no conflict of interest to disclose. As introduction, I hope to cover three main subtopics. The first would be type 1 diabetes, second type 2 diabetes mellitus, obesity. So these are the three main topics that hopefully we'll be able to cover this morning. As introduction, diabetes is a disorder that causes high blood sugar or high blood glucose in the blood. We all know this. It occurs not only among adults, but also in children. So we have to be aware that it is a disorder in children as well. Although most commonly it affects adults in worldwide and Malaysia particularly. The two most common types of diabetes in adults and in children and adolescents are type 1 diabetes and type 2 diabetes. These are the two most common diabetes. There are other types of diabetes as well, but in children, these are the two most common affecting children and adolescents. Type 1 is the commonest type of diabetes affecting children and adolescents. As we know, in adults mostly is type 2, but when we talk about children and adolescents, type 1 is the most common diabetes affecting this age group. However, I have to say that type 2 diabetes, although not common, but is increasing in trend and becoming an alarming public health concern worldwide, and Malaysia not exclude Malaysia. Malaysia is being affected with the same trend as well. This is highly contributed by the increasing prevalence of obesity worldwide and in our country as well. How do we diagnose diabetes in children? It is the same as the diagnosis of diabetes in adults. So you have sugar, your plasma sugar concentration of more than 11.1, or if you're fasting, the plasma glucose would be more or equivalent to 7, or the other criteria, if you you do oral glucose tolerance test, it would be 2 hours post OGTT would be more than 11.1, and the fourth criteria, which was added recently, is HbA1c of more than 6.5%. For those who don't know, HbA1c measures your blood sugar or your glycemic control for roughly about 3 months duration. So when you talk about symptoms, I like this. That's from Diabetes UK. They in order to educate general public, they go by 4 T's. What are the 4 T's? The first T would be toilet, meaning they're going to the toilet to pass urine more often. The second T would be tired. They're lethargic, feeling tired. The third one would be thirsty. They're drinking more often in frequency and duration. Drinking water, they have increased thirst. And the last T would be thinner. So they have weight loss that is measurable. So these are the 4 T's that has been in order to try to educate the general public of what are the symptoms to look for in these children. So we go to our first subtopic, will be type 1 diabetes, since this is the most common diabetes affecting children. So it is characterized by chronic immune-mediated destruction of pancreatic beta cells, which leads to partial, or in this case, usually absolute insulin deficiency. So in type 1 diabetes, there's no insulin available in the body from this autoimmune process. So when we say at type 1, it is autoimmune in process. So hence, when it is autoimmune, so usually when you send blood for diabetes autoantibodies, most of these patients will have positive, highly raised autoantibodies. And the etiology is multifactorial. Some say genetic, you have environment, but however, this remains unclear until this day. So what about epidemiology? The incidence varies greatly between different countries and different ethnic population within the same country, and obviously differs between different ethnic origin from different countries as well. And it is reported to be highest in Finland, Northern Europe, and Canada. And of this estimated 500,000 children with type 1 diabetes, approximately 26% would be from Europe, another 22% from North America and the Caribbean region. So if you can see, more than 50% of the children with type 1 diabetes are from this region. What about in Asia? The incidence of type 1 is very low. If you see in Japan, it's only 2 per 100,000 person per year, China 3.1, Taiwan 5 per 100,000 children per year. Remember that I said that Finland has been reported to have the highest incidence. In Finland, it has been reported having incidence of 63.4 compared to the regions in Asia. So this is a publication by Prof. Maria Craig. If you see here, this is what, when we say Finland has been reported to be the highest, Asia is somewhere down here. We do have our neighboring country, Thailand, is way down here. Unfortunately, we don't have Malaysian data to report the incidence at the moment. Yes, we mentioned about the symptoms, but if we want to divide the symptoms into early and late, So you have the early symptoms we mentioned earlier, the 40s, polydipsia, polyuria, weight loss. This is important, especially when you're talking about children. The secondary enuresis means bedwetting. So if let's say a patient or mother comes to you saying that, is for example, a 10-year-old who has been definitely toilet trained, no bedwetting whatsoever, but the last 2 weeks, for instance, having some incidents of bedwetting, so that is a red alert that, as a physician, you have to be aware of that. And then we have late sign of diabetes. If you don't catch them early, they will continue on to have these symptoms and later have late manifestation of the diabetes. What are the late symptoms? This include vomiting, dehydration, abdominal pain, hyperventilation or rapid breathing, and later on they can present with drowsiness and coma. Of course, we don't want these symptoms. These late signs, so ideally you want to catch them early, and the most important thing I say that we have to increase the awareness. So at least patient parents are aware of the early symptoms, they can present earlier rather than catching them at the late stage. This late stage is the early complications, the late complications of the early onset diabetes. That is what we call diabetes ketoacidosis. So you don't want them to come to you in diabetic ketoacidosis or what we going to refer to as DKA. Despite increasing awareness, high number of newly diagnosed type 1 children still presents with DKA. The rate of presentation with DKA at the onset of the disease ranges between 15 to 17% in Europe and North America. We have our own data, but it's dated 2008. Dr. Fuzia and her team reported that in our Malaysian population, at the onset of diabetes, children presents about, if you see here, about 57.1%. The first presentation with DKA. So we are still a lot more to do to increase the awareness so that we hopefully reduce the incidence of DKA at presentation. Obviously, the incidence of DKA should be lower in countries where type 1 diabetes is more common, because the more common they are, the general public are more aware and the medical professionals are more aware of the symptoms, and it's just simply by checking the blood sugar and then you'll detect that the patient has diabetes. What are the morbidity and mortality of DKA? Mortality rate, death rate from DKA has been reported to be 0.15% to 0.3%. Cerebral injury is the most common cause of morbidity and mortality. Among the cerebral injury, the cerebral edema, whereby your brain is a bit swollen, is the most commonest complication of cerebral injury. We reported in 2018, we had a patient which we published the case. This was a newly diagnosed type 1 diabetes who presented with DKA, and she had expressive aphasia, so she lost her speech during the episode of DKA, and also she had weakness of her limbs, upper limbs or lower limbs, and she was, from the scan, she was noted to have ischemic hemorrhagic stroke. So this is not the, we mentioned that the commonness would be cerebral edema, so she had the uncommon manifestation or complication of DKA. But and we stress in this paper that it is very important to have close monitoring, not to miss any of these severe and fatal complications. So she did well after that. She subsequently recovered, and her speech recovered, but she has very minimal residual weakness on her one side of the limb. So when we talk about type 1 diabetes treatment, remember the patient does not have insulin, is not able to produce insulin, hence the treatment would be supplementing exogenous insulin into the body. So at the moment we have multiple of insulin available via injection subcutaneously. So patient at least 4 to 6 times per day. That is what we call basal bolus. So imagine we're trying to simulate what happens in our body physiologically. So we try to mimic by giving extra exogenous insulin to try to maintain the blood sugar within the normal range. Not just insulin injection to maintain the blood sugar. Definitely patient would need blood sugar monitoring regularly because they want to know what's the sugar level, and they would like to know how much extra correction of insulin doses they need to give. Hence, regular blood sugar monitoring is vital in these patients. The advancement of technology in the medical field is really impressive. So we have an option of having insulin pump. If you see here, it is really handy. It's very small. The insulin pump has the insulin reservoir inside here, and then you can just click the button here to deliver the insulin through the tubing, and this will deliver your insulin via the infusion set here. So this usually needed to be changed every 3 days. So some patient who doesn't like the injections multiple times per day, they can opt for this option. But of course, it doesn't come cheap. But those who can afford it, this is another option. And then you also have glucose, some that have glucose sensor. So these can fit in the sugar level, like 24 hours reading of sugar level into this machine, and then you would know the blood sugar level throughout the 24 hours a day. Type 1 diabetes, of course, there's plenty of complications. It's the same with type 1 and type 2. You have retinopathy affect the vision. You have nephropathy affecting the kidney, neuropathy. You have your macrovascular complication, your cardiovascular, your stroke complication, and so on. So hence, the need of good blood sugar, good glycemic control to reduce the risk for complications. We managed to present a poster at one of our conference. Zaki was our student who's currently doing housemanship at the moment. So we presented on diabetes nephropathy as one of the complications among adolescents with type 1 diabetes mellitus. So if you see that the incidence is quite, we don't have high incidence, hence the importance of collaborating with our other colleagues. For this instance, we collaborated with our colleague in UMMC. So from this data, we managed to gather about 109 patients of type 1 with a mean age of 15.3 years. And what we found that in the total population of type 1, 10.1% has been diagnosed with diabetic nephropathy. And if you see in the table here, of course, as expected, the higher the HbA1c, meaning the more poor the glycemic control. If you have poor glycemic control, hence definitely you have higher chance of getting diabetic nephropathy. So that's what we're trying to avoid or reduce in our patient population. So what we concluded that the children and adults with type 1 may exhibit earlier changes of diabetic nephropathy. Poor control is a known contributing factor. Hence, we need to screen more often and educate patients intensively to make sure that their glucose control is within normal range. Next, we will go to the next subtopic. Will be type 2 diabetes. This is very common in adults, but do happens in pediatric population as well. So this occurs when your insulin secretion is inadequate to meet the increased demand posed by insulin resistance, leading to relative insulin deficiency. Remember that your type 1 diabetes has absolute insulin deficiency. They don't have insulin, but in type 2, they still have insulin, but you have tissue insensitivity, meaning even though you have insulin, but the action of the insulin on the body is inadequate or insufficient to maintain your blood sugar within the normal range. Generally, type 2 diabetes would associated with other metabolic abnormalities associated with insulin resistance, for example, dyslipidemia, high blood pressure, hypertension, polycystic ovary syndrome, PCOS, and also fatty liver. Today's study is a very big study, famous study on type 2 diabetes in children and adolescents. So what they found was comparing between children, adolescents, and adults, they found that the rate of beta cell function deterioration in children and adolescents is 4 times higher than adults. Even though we say there's no problem with it's not autoimmune process, but you do, over time, you do still see that the beta cell function is deteriorate, and the deterioration are worse in children compared to adults, which is worrying. And in children, the decline of the deterioration would be 20 to 35%, as compared to adults, it is reported to be 7 to 11%. Children and adolescents with more advanced diseases at baseline experience progressive and more rapid weight loss of the beta cell function and were unable to maintain satisfactory glycemic control. There are risk factors for type 2 diabetes. Number 1 would be genetics. You know, being in our part of the region, we have a strong genetic preponderance for type 2 diabetes, unfortunately. And then you have environmental risk factors, which includes nutrition, obesity, and physical inactivity. Complications similar to your type 1, you have microvascular, you have macrovascular complications. In today's study, they reported that children and adolescents suffering from the same complication as adults, but with faster progression. So the complications are similar, but the progression of the complication is faster in children. Hypertension, you can see hypertension, microalbuminuria, lipid disorders, they are all increased after about 4 years duration, and these are common in children with type 2 diabetes, children and adolescents. What are the clinical presentations? We have a similar clinical presentation of type 2, classical polyuria polydipsia, weight loss, ketosis where you have high blood ketones, and also they may present with DKA as well. Some people think that type 2 patient does not present with DKA. They still may present with DKA, although it's rare compared to type 1. Non-classical would be some type of infection that is slow to heal. Children can also be asymptomatic. They don't have the symptoms, but they may be picked up from a routine screening of blood sugar, for instance. Diagnosis is the same. Bear in mind for this diagnosis, if a patient denies any symptoms of polyuria, polydipsia, lethargy, for instance, you need at least to confirm the blood test on the next subsequent day or subsequent time, because you can't rely on one reading. But if they have symptoms, one reading is sufficient. This is nice to see the difference in clinical features between type 1 and type 2 children and adolescents. Type 1 have a wide range of onset from as young as 6 months to young adulthood, whereby type 2 is usually around pubertal age or later. Presentation is more acute in type 1, and with type 2 they are more variable in onset. Positive autoimmunity in type 1, ketosis common type 1 compared to type 2. Type 1 diabetes, usually they are more lean, they slim, but because of the increasing trend of obesity, bear in mind that type 1 diabetes may be on the obese or overweight side as well. As we know, type 2 usually they are more overweight and obese. Acanthosis nigricans, I think I have a slide on that, is typically absent with type 1 diabetes, but with type 2 they are commonly present. This is the skin manifestation. So I mean, when I mentioned that it's not as easy to differentiate between type 1 and type 2 nowadays because of the increasing prevalence of obesity worldwide and also in our country. So we presented there's a case where we misdiagnosed a patient who presented to our care. So this boy came in and was he was overweight, and he has acanthosis all over his body. Hence, we treated him as type 2 diabetes because of the symptoms and his what we see at that point, and later, about a month later, when the results of insulin autoantibodies came back, and the antibodies were hugely raised, and we then changed the diagnosis to type 1 diabetes mellitus. So it is not as easy as before to make a diagnosis. You need help with your lab work, lab results, and so on to make the right diagnosis. And later on, because of this, we have changed the patient from metformin, from oral medication, we changed the patient to insulin therapy. Yes, this is examples of acanthosis nigricans. This is a skin manifestation, can be present around the neck area, around the axilla, your armpit, and also some other flexural areas, sometimes on the knuckles as well. In children, sometimes we say, is it like just some dirt or something that, they're not cleaning themselves properly, but it is a sign, especially in obese and overweight children, it is a sign of insulin resistance, a sign of pre-diabetes. If it's not catch early with intervention, they can evolve to be a full-blown diabetic. So we mentioned about pre-diabetes is a term that designated this ADA, which is American Diabetes Association, designated this physiologic state pre-diabetes to recognize the high risk group from progression into being diabetes in adults or even in children and adolescents. So what are the what do we mean by pre-diabetes? That's impact. They may have impact fasting glucose, whereby the fasting glucose is not diabetic range, but it is below that, which is from 5.6 to 6.9. They might also have impact glucose tolerance. This is usually from your OGTT or glucose tolerance test, and they have HbA1c between 5.7 to 6.4%. So it's good that if we're able to detect a bit early before they become diabetic, so that we can give the necessary intervention. What about management? Type 2 diabetes in children, of course, with anything, diet, lifestyle changes has to come first. Metformin would be the only oral medication licensed in pediatric population. And if metformin alone does not work, you have to add on insulin to help control the blood sugar level. Usually we start with once daily dose of insulin, but of course if this fails, you need the insulin post basal bolus insulin as your type 1 diabetes to control the blood sugar level. Bear in mind your target HbA1c will be less than 7%. What's new This has been released last year. My supervisor from Prof. Yazid is among the writing committee here. Liraglutide is another medication, subcutaneous injection, which has been approved in children from 10 years of age with type 2 diabetes. So this is just newly approved by the FDA. By the FDA. Okay, last topic would be obesity. It is very common. Pediatric obesity is a persistent epidemic and international problem. Preventing pediatric obesity and its comorbidities would be paramount importance. Obese children are likely to stay obese into adulthood. So we have to be aware, some of us think that, when they're obese during childhood time, when they grow up, they'll be usually that will resolve. So we have to bear in mind that, obese children are still likely to stay obese to adulthood. What about epidemiology? The prevalence of obesity, if you look in the USA, age between 2 to 19 years, it has been reported to be 17%. Although the overall rate of child and adolescent obesity has stabilized over the last decade, after increasing steadily for the 3 decades, obesity rates continue to increase in certain population. For example, African American and also Hispanic population. Recent report also showed positive linear trend among children 2 to 19 years, and this is most prominently in adolescent. So if you can see here, this is what I was referring, that you have a linear trend of increase in obesity and overweight in the children adolescent population. What about in Malaysia? In Malaysia, this has been recently published by the National Health and Morbidity Survey 2009, NHMS. This is in adults. Quite surprisingly and worryingly, adults in Malaysia, 1 in 2 of adults in Malaysia were either overweight or obese. Females represents about 54.7%. So this is highest among female. And abdominal obesity as well, when you or your central obesity, your waist circumference, also 1 in 2 adults in Malaysia had abdominal obesity. Again, similarly, highest among the females. Indian ethnicity represents the highest among these statistics, and those are the age group 55 to 59 for the overweight and obese, and 60 to 64 among for the abdominal obesity. So this is, I say, a worrying trend because you see the numbers are getting higher and higher. We are also the champion in the Southeast Asia. This is the data from WHO. Again, among the adult population, overweight prevalence for adults of both sexes. These from all the Southeast Asia, comparing the Southeast Asian countries, we are the highest, fattest, 44.2%. Even the Thailand will be the second one after Malaysia. So not something that we should be proud of, I would say. What about in children? Also not far behind. Child obesity in Malaysia, the second highest Asian. We are behind Brunei. Brunei has 14.1%, and Malaysia is 12.7%. So a lot to be done here because we don't want this trend to continue to worsen. Epidemiology, we have another epidemiology data, again from Prof. Aziz's group here. In Malaysia, a study reported that the prevalence of overweight and obesity among 13 years old adolescent was 25.4%. So imagine 13-year-old, our 13-year-old children, adolescents, 1 in 4 would be either overweight or obese in our country. So how do we diagnose obesity in our children and adolescents? We go, of course, BMI is the most common, body mass index, BMI is the most common method that we use, but single number of BMI doesn't mean much for pediatric as compared to adults. You calculate and then you know whether you're obese or overweight. But in children, we have to refer to BMI centile chart to know whether these children are really overweight or really obese. So overweight is defined as BMI more than 85th percentile, but below 95th percentile. Obese is BMI more than 95th percentile. I have the chart to show after this, and there's another category of extremely obese if the BMI is more than 120% of the 95th percentile. So these are the charts that I was referring to. You have a girls chart and boys chart, color coded pink and blue. If I can demonstrate here, if that is the 85th percentile line. So if you plot the BMI for your child above the 85th percentile, that would, the child is considered as overweight. And if you plot, and some of the patients in my clinic, you can't even plot because it's way beyond the centile. So above the 95th centile line, that would be obese. So just imagine, again stressing that the one number of BMI doesn't mean much in pediatric age group. If you see here, let's say you have BMI of 21 here, right? 21 here may be normal, of course, in adult, but if you talk about pediatric population, that is already above your 95th percentile, which is obese. Comorbidities, you have endless list of complications and comorbidities of obesity or overweight. It's head to toe, from psychosocial, from lungs, pulmonary complication, gastrointestinal complication, renal, musculoskeletal, neurological, cardiovascular, and also endocrine complication. We know obesity, if worsened and not treated, and this can continue to turn the patient into being a full-blown diabetic type 2 diabetes patients. Hence, I feel that prevention is the most important thing. Is vital, prevention of obesity, to reduce the risk of further complications or comorbidities that we have listed down earlier. And early detection of children and adolescents with obesity is very important, because if you are able to detect, the medical professionals and or even also the parents of the children are able to detect that something is not right, you're not happy with the children's weight, then only able to take necessary preventions, you adopt a healthier lifestyle and so on, or bring your child to get medical attention. If you're not able to detect, you don't recognize that as a problem, an issue, of course, a necessary precaution, necessary intervention will not be carried out. So I was thinking of, it's interesting to see whether parents have the right perception of their children's health, or in this particular instance, the weight of the child. So we embark on a study that we look at the the perception, the parental perception of the children's weight status, and also we wanted to also look at the socio-demographic factors associated with childhood obesity. So if we can see what are the factors, socio-demographic factors, hopefully we can see which are the target group that we may need to spend more time with. And if you see here, from our study, if we look at the obese and overweight group here, the total sample of our patient was 245. So you could see that most parents in the obese and overweight group of, if their kids are obese or overweight, they more than 50%, and even here more than 80.5% thinks that their children are still have normal weight. So if, let's say, this shows that parents might not be as aware that there's some issue to be dealt with here. Hence, of course, necessary intervention or change in lifestyle will not take place here. So interesting, something that maybe we need to explore more in the subsequent study, hopefully. So we concluded that most parents of either obese or overweight had inaccurate perception of the status of weight of their children. Perhaps you understand that maybe they're slightly overweight. Sometimes parents might not think that to be abnormal or to be an issue, because with the increasing prevalence of obesity nowadays, but you do see parents even in the obese children group still do think that their kids have normal weight in that previous study. And again, we look at the socio-demographic risk factors. What we found from the study, I know this is a busy table, just to conclude that we found that higher household income, higher birth weight, and higher education level of the mothers, as well as of diabetes and obesity in the family, associated with increased risk of childhood obesity in that population. So when you talk about obesity, type 2, diabetes, you can't run away from the two terms of insulin sensitivity and also insulin resistance. What do we mean by insulin sensitivity and insulin resistance? Insulin sensitivity describes how sensitive the body is to the effect of insulin. Of course, we want our patient to have more sensitive to insulin, whereby insulin resistance is a condition which cells fail to respond normally to insulin. So our obese patients have higher risk of having insulin resistance, and when it worsens, they will become type 2 diabetics. So it is important, like I mentioned, to deal with this group of population, this concept. Hence, there are multiple of markers that has introduced worldwide to predict insulin resistance, because there's no way that we can measure your actual, because the gold standard for measuring insulin sensitivity is by a clamp test, which is very invasive and has been done in research, properly researched lab, and very time consuming. So that's why multiple of markers, when I say surrogate markers, blood tests that can show you whether your patient has high insulin resistance or not. So examples of the surrogate markers would include your TG-HDL ratio, fasting insulin 1/1 called triglyceride glucose index, TYG index. So at that point, when we decided to do this study, was the TYG index marker as a surrogate measure of insulin sensitivity in children and adolescents was not reported before this. There was other markers. It was reported in adults but never reported in pediatrics. So that's why we embarked on this. This was at the Pittsburgh, where I was was there for 1 year during my subspecialty training. So we managed, because it was a really well-versed research center, they have the hyperinsulinemic euglycemic clamp from time to time. Hence, we are able to compare these markers with the gold standard to see which marker is the best among this surrogate marker. So what were the aims? We wanted to assess between the TYG index to compare that with the in vivo insulin sensitivity using the clamp in obese adolescents from being normal obese, but they have normal glucose tolerance, to pre-diabetes being diabetic. And we wanted to also compare between the TYG index and other markers that we mentioned just now to see which one is the best in predicting the insulin resistance. So what we found was that TYG index, it is useful to be utilized in epidemiological, observational and interventional studies in the follow-up of obese at risk for type 2 diabetes. Although from the study we saw that it is not superior to 1/over fasting insulin, but it offers an advantage of having another method, because fasting insulin sometimes is variable depending on which lab you use. You might have different readings, for example, depending on the assay, but TYG index is more standardized because you measure TG and you measure glucose. So this is an option. I think before we end, another important concept or important thing to disorder to note is metabolic syndrome. We hear this from time to time. It's currently recognized as a major public health problem. Represents a cluster of risk factors consisting of central obesity, dyslipidemia, hypertension, hyperglycemia, and also insulin resistance. This also occurs in pediatric age group. If you see the diagrammatic representation here, metabolic syndrome must have central obesity. You have high waist circumference, and they may have, to make a diagnosis, you should have at least 2 or more these four criteria: low HDL cholesterol, high TG, insulin resistance, and hypertension. In iPerform, we managed to publish this paper, but although this is not in pediatrics, mostly from 30 to 65 years of age, we managed to look at the samples of patients with central obesity, comparing with metabolic syndrome, and look at their proteogenesis marker. So we look at TPA, PA, PI1 in this study. So from the study, we can conclude that central obesity, patient with central obesity with or without MS, if some does not qualify to be MS, both of patients demonstrated enhanced proteogenesis, and this suggests that simple obesity itself is possibly increases the risk of coronary artery infarct due to the thrombogenesis. So that's what we concluded. I think those are the things I would like to share this morning. Just to summarize, diabetes occurs, remember that it's not only occurs in adults, but also in children and adolescents. Obesity prevalence is increasing and necessitate urgent detection and prevention to reduce the risk of future complication worldwide, and also particularly in our country, and hence ongoing research in this field is greatly required. I just like to acknowledge the collaborators, faculty, iPerform definitely, and all my other collaborators, ongoing collaborators that might not have time to share here. And with that, I thank you. Back to you, Pro Alice.
Thank you very much, Dr. Shafina. Sorry. Okay, for your informative and excellent presentation. I guess now most of us have been alerted with the sign and symptoms of this diabetes and obesity. The fact that you share the acronyms are 4Ts, easy to remember not only for us as a practitioner, but also for public out there to know these features of this diabetes mellitus, toilet, tired, thirsty, and thinner. So we need to be extra careful with these symptoms, sugar-loaded food, and aware of our kids' BMI. And it is also so sad that you shared that we are now among the highest prevalence in obesity in both cohort, adults and children. So we hope that we can improve the statistics for better health in the future. Huh? Sorry, can you hear me? Yeah, champion.
No, champion.
The better. Okay. Okay, let me check if there is any question. Oh, quite a lot. Okay, from Dr. Zainuddin Zakaria. Okay, salam. Why are some diabetes patients did not lose their weight? Usually those who are obese. So any reasons, Dr. Shafina? Some diabetic patients did not lose their weight.
Thank you for Zainuddin. Sorry, I can't see here. Okay, thank you for the questions. Yes, we do say that among the common symptoms would be weight loss. Why? That's
echo. Okay, yeah.
Okay, okay, better. Weight loss is one of the common symptoms of diabetes. But perhaps if you detect those patients early, so they may not have significant weight loss at the time of diagnosis. Because why do they have weight loss? They are losing glucose in the sugar, hence they will have polyuria. With that polyuria, they will drink more because they want to replace whatever they have lost, and that will cause them to have weight loss at the time of diagnosis. But perhaps if you catch those patients early, they might not have significant weight loss as well. Or the other thing I was thinking, maybe perhaps if you have type 2 diabetes, remember we say that type 2 diabetes might be there for many months or many years even before you can diagnose them. You diagnose them to have diabetes. So maybe this patient, because of the nutritional factor, when they might lose weight because of the disease process, but because they have the eating habit is unhealthy, so maybe the effect of weight loss is not seen there. So possibly those explain the reason.
Okay, hope that answered Dr. Zainuddin's questions. He also got another question. Is honey a good source of sugar for diabetic patient? Is honey?
Alright. Thank you for the questions. I suppose honey being some sunnah, definitely I suppose you can have honey, but anything too much is also unhealthy. You have to consider, you have to take them into consideration, because honey is also high in sugar content. So we don't advise patients to take a lot of honey, because that can also increase your blood sugar level. Just to share that our type 1 diabetes patients, because they are on regular insulin, multiple daily dose of insulin, sometimes they may become hypoglycemic. For example, if they inject too much, the dose is too high, or they eat less, for example, they may become hypoglycemic. We define hypoglycemia to be less than 4 millimole per liter. So honey is one of the thing that we said they can take because it increase your blood sugar quite high. So if you see that, honey can increase your sugar quite high. So that's why we don't really, you can take, but of course, bear in mind it has in small amounts.
Yeah, so Dr. Shafina, is there any recommended, maybe artificial sugar that can replace this sugar? Because some people, especially children, they can't tolerate with no sugar at all. So if you can suggest any artificial sugar that can replace this sweetness.
We don't really. Of course, we advocate low sugar content, but we try not to say that you can't take any sugar. You can't take any sugar at all, because sugar is also, especially with type 1 diabetic patients, they still need to the energy, for example, like when you talk about sugar, carbohydrate, we're not saying that okay, you can't take any carbohydrate at all, any sugar at all, but of course it has to be tally with what the amount of insulin they're injecting. For example, if they're for breakfast, they're eating a certain amount of carbohydrate, a certain content of sugar inside the food with carbohydrate. So they have to know how much injection they need to inject, how many units of insulin they need to inject. So if they're eating more during daytime, during breakfast time, so hence they have to inject more. Back to your question, Alice, about the sugar replacement. I am not recommending any sugar replacement, because not to say that you can't take any, but ideally, because sometimes you don't know what's the content inside your sugar replacement, kan? Because to make it sweet, sometimes you will have to add something else. So I would rather try to take sugar in moderation, especially we're talking about type 2 diabetes. Bear in mind, the quantity, the amount has to be really thought of as well in our patient.
Okay, understood, Dr. Shafina. Thank you. So another question from Dr. Zanuddin too. Can ED caused by diabetes be cured permanently? I assume erectile dysfunction is one. Can ED caused by diabetes be cured permanently? If yes, what is the most effective procedure or treatment?
Can ED, erectile dysfunction?
Yeah, erectile dysfunctions.
Oh, okay.
Fina is fit, but maybe you find a clue of those who reach puberty, they can have like this ED problem.
Yes, yes, one of that is definitely one of the complication luckily in our pediatric population. Of course, we sometimes we do we're lucky that we can catch them early. We don't really see the complication of erectile dysfunction until a bit later. So of course, my adult endocrine colleague might see that more prevent is better than cure. With your trying to improve your glycemic control, meaning to improve your blood sugar, hence that you don't reach the stage that you have your other complications. You don't want to be having dialysis at the age of 20, because of the poor complication, even from the early childhood area. So just imagine if a child has been diagnosed as early as 2 years or 3 years, so they have a long way to go with good control, with good diabetes control. They should be not living as normal as other peers, because they have good sugar control. So that's what we're trying to aim for in our patients.
Okay, Fina, another questions. If that patient is diabetic type 2, it can be cured permanently or not?
All right. So yes, for patient with type 2 diabetes, I mean, like, if you have diabetes, you have diabetes. Okay, so once you're diagnosed with diabetes, you have diabetes type 2. But of course, we have to we have to change our lifestyle intervention in terms of diet, being healthy. If let's say we have good lifestyle changes, sometimes who are on medication might be able to wean off the medication. I have patients who be diagnosed with type 2 diabetes, started on oral medication, metformin. The sugar control was very good. Your HbA1c reduced significantly. So we managed to cut down the dose of the medication, and managed to off the metformin and control with lifestyle intervention. But of course, if let's say they're being complacent or back to their old habits, so we have to warn them that they may need to be restarted on the medication back again as before.
Okay, right. Next question. She mentioned that she got last follow up with doctor and her sugar level was 14.7 and 3 months ago, and her next visit is 3.4. What does this indicate? So from 14.7 3 months ago to 3.4. So what does this indicate?
Right. So thank you for the question. Okay, so when the sugar is 14.7, definitely the sugar is high, and definitely the patient has diabetes. I assume here is type 2 diabetes lah, if we're talking about adults, because if fasting is more than 7, is already diabetic. If a random blood sugar is more than 11.1, is already diabetic. So either way, if the blood is fasting blood, or if the blood is random blood, meaning it's not fasting, 14.7, either way patient has diabetes. So I'm not sure whether the patient, whoever was asking, is already on treatment, and what forms of treatment, when the next blood taken, the sugar was 3.4. So either, if let's say the patient is on treatment with insulin, so definitely insulin may cause you, let's say, the insulin, they took insulin but did not eat, and hence that will cause them to have hypoglycemia. Less than 4 millimole per liter is hypoglycemia. 3.4 here is hypoglycemia. So that is one reason. There are some medications as well. Diabetic medication as well may cause hypoglycemia as well. So I think really need to explore with your with the doctor attending what are the possible causes for this patient to have hypoglycemia at the time of for the doctor, for instance, before you take the being patient, my patient as well may have some hypoglycemia at the at that point.
Okay, all right. Maybe another quick questions. Okay, from Prof. Dr. Tanwini. How is can you hear me? Another question, Fina. Just like three more questions.
Yeah.
How is mother's education level associated with childhood obesity? Do you have any data or you know about this? Mother's education level. How is mother's education level? Probably
why?
There is some study showing this.
Okay. Referring to our data, actually, when we mentioned about the mother's education level, so from what we saw was the higher the mother's education level, I suppose the more obese, overweight the child, their children were. So that was interesting. But I suppose with higher education level, they because now the higher education level, the more access you have to food, for instance, I'm not really sure. That was really interesting to see. But I can't remember on top of my head. From the literature search, there was another publication also showed similar findings, whereby they look at the education level of the parents. I think that was both parents, and it is more associated with more associated with childhood obesity in that paper as well. So I mean, like, it is something that we really need to explore more, because some findings are, can be conflicting. You do have other findings that say that, if you compare rural and urban and so on, so there are a lot of data coming up as well.
Okay, yeah, it's an interesting question. Maybe you can explore further about these associations. Probably can collaborate with this Dr. Tanwini. Okay, next.
Yes.
Where can we bring our children for checkup? Can we just go to any clinic, or you need to set appointment with pediatricians?
All right. Thank you for the question. Actually, all medical doctors are supposed to know how they should be able to, any doctor should be able to do the first screening. And then from the first screening, if needed, they can give proper advice, or hence refer to the local pediatrician, which can monitor and screen as well. And if needed, they can refer to other necessary subspecialty lah. If they are concerned about diabetes and so on, they refer to pediatric endocrinology, like myself, for instance. So to begin with, you can go to any medical doctor. That they should be able to do the first screening.
Okay, that's good. Alright, Fina, this one, adakah cukup sekadar membuat pemeriksaan kesihatan, medical check-up setiap tahun, termasuk mengesan awal diabetes? Is it enough? Just do a yearly check-up to detect diabetes?
Alright. Yes, thank you. Thank you so much. Of course, it depends on each patient will be different depending on how's your risk. What are your risks? Risk being whether you have the genetic for diabetic, whether you're obese, whether you're overweight. But if let's say you don't have any risk factor, for instance, I feel yearly assessment is sufficient. But of course, if you have higher risk and so on, your medical doctor, your physician may advise differently, meaning having a more frequent follow-up or so on.
Okay, so the last three questions. Okay, what is the correct age for mother to control the children's food intake to avoid diabetic complication in the future? Correct age for mother to control children's, what maybe the average age? When is the time
for the child?
Yeah, for the child.
All right. Okay. I mean, like, it's actually if you're talking about interestingly, if you're talking about obesity, there are new evidence to say that it's not just it's not just about a matter of the child alone. It started off even with the mother. The previous data showed that mother has to take care of her health and her weight even before she planned to have the baby. But the more recent data showed that it's not just the baby, the child, the mother. It extended even beyond earlier from your grandparents. So it is interesting to see how this your epigenetic and so on play a role. So I thought that was really interesting to show that we have to continue, like everyone should take to play a role. Like if for me, you have to think about you should start taking care of yourself, for your kids, and not for just for your kids, also for your grandkids in the future. So just to answer the question, I mean, it should continue from, from being pregnant and so on. I mean, I suppose in children, let's say like you just have the baby and then, there is a newborn baby. Of course, you want to give them, you still have to take care of your newborn baby, even though the newborn baby. We say that breastfeeding is the best because, some studies have shown that breastfeeding, if you breastfeed your child, that reduces the risk of later risk of childhood obesity and in later age. So even from before, you have to continue to monitor what your child take and so on. And then later when they start having other solid foods, of course you have to make sure that they are eating healthy solid foods. I know I'm to blame also. You have you have children yourself. Try to make sure that what they are eating always healthy is always a challenge. But that is what we have to do as a mother.
Yeah, okay. Can we reverse diabetes type 2? Another question.
Oh, that one similar lah.
Okay, we already answered that one. We can skip. How to maintain our glucose in blood, even take the clean diet, not take the sugar at all, and regularly exercise. If diabetic type 2, is it possible to take insulin rather than metformin?
Okay. So yes, exactly. Thank you for the question. To control how to maintain our blood glucose in the how to maintain our glucose in the blood. All right. Okay. So it depends on the type of diabetes. Of course, we advocate to minimize your sugar intake in your food content. How to maintain normal blood sugar. If you are talking about type 2, mostly of course be aware of what you eat. Try to minimize sugar and carbohydrate content in your food if you're type 2 diabetic. But if you're type 1, and we say in our lecture that type 1 is mostly in children, you can't really say that, okay, don't eat. Okay, your peers will eat one full plate of rice, or for instance half plate of rice. You don't eat. You don't eat rice because you have diabetes. No, that is not what we advocate, because children needs to eat because they are growing. Let's say if you really minimize what they're eating, they'll be stunted. That's a different problem that will come to you if you say, okay, you can't eat, skip your breakfast, for example, because you have diabetes. That's not what we advocate. If they're type 1 diabetes, they still have to eat healthy food, but you have to adjust to okay, so you have to really tailor your management of the blood sugar properly. The other question, so I can't see the second question too. It was about,
is it possible to take insulin rather than metformin?
At least the second question.
If diabetic type 2, is it possible to take insulin rather than pills, rather than metformin? Nampak tak, Fina? Can you see that? Can you hear that, Fina? If diabetic type 2, is it possible to take insulin? She said, okay. If patient is diabetic type 2, is it possible to take insulin rather than metformin? They want to take insulin.
Can you hear me?
Yes, I can hear you. Hello? Okay. But it's okay because we are about to, that will be the last question. If diabetic type 2, is it possible to take insulin rather than pill metformin? I think I may post these questions and let Dr. Shafina probably reply through live chat in Facebook probably, so others can see what will be her answer. So because for the interest of time, okay, I have to stop our Q&A, and I'm sure there is lots of questions people out there wanted to ask, and I think you may email directly to Dr. Shafina, okay? And I would like to thank Dr. Shafina for spending her time and knowledge for this session. Okay, you can also actually reach her at a pediatric clinic in our Pusat Perubatan Pakar UITM or UITM Specialist Center. Okay, with that, have a good day and enjoy your weekend, everyone. So sad that Dr. Shafina couldn't say last words to all of you, but I'm sure all of you got benefits from this talk. Okay, so if you have any further questions or any future research collaboration, you may reach Dr. Shafina through probably maybe through emails, and you if you need further consultancy, you probably can contact Pusat Perubatan Pakar UITM. She's in service in public, and also we have a private clinic. Okay, so with that, thank you everyone for listening. Okay, hope to see you guys in next webinar, inshallah. Okay, thank you very much.